purpose of the immune system is to protect the body from invaders. These invaders primarily take the form of bacteria, virus, fungi, and parasites. We are exposed to many organisms every day. The efficiency of the immune system prevents disease despite this exposure. Immune system failure can be the result of a primary or congenital immune deficiency in which one or more of the parts of the system are not functioning properly from birth. These problems are usually genetic mutations that are discovered in the infant child who is repeatedly sick. Immune system failure can also be secondary, acquired after birth, as the result of viral infections like HIV, contact with a toxin, or medical therapy such as chemotherapy. Acquired immunodeficiency syndrome, AIDS, is the most severe form on a continuum of illnesses associated with the human immunodeficiency virus, HIV. HIV targets and destroys CD4, or T4, cells. The hallmark of this disease is a suppressed immune system which leaves a person wide open to contracting an opportunistic infection. HIV literally hijacks the T4 cells. Once inside the cell, it forces the cell to copy itself and then go to infect other cells. The virus contains proteins on its outer surface which will try to dock onto the receptors of the T4 cells. The virus carries along with it an enzyme called a reverse transcriptase, RT. RT makes it possible for the genetic material in the virus to convert to the genetic material on the T4 cell, which is the conversion of a single-stranded RNA in the virus to a double-stranded DNA to match the T4 cell. The enzyme integrase allows the virus's new converted DNA to worm its way into the T4 cell's nucleus. The enzyme protease clips the new, nasty genetic material into lots of pieces. All of the new pieces gather within the infected cell, and finally you have a T4 cell that it is not itself anymore, but a virus. It's no longer a nice and helpful T4 cell that would ordinarily direct the immune system. Now it's the virus carrier that will go around and infect more T4 cells. Initially, the patient's immune system will destroy the infected T4 cells, which are really viruses now. But eventually there are just too many viral cells and not enough uninfected T4 cells. The first challenge is for the HIV particle to get inside a host cell. HIV accomplishes this task by first finding a way into the host's bloodstream. Once in the blood, HIV hijacks certain cells. If HIV successfully enters a CD4 or plus T cell, it can then create more viral particles. When a person is infected with the HIV virus, infected cells randomly bump into many other cells. The docking proteins on the outside of the virus cell try to find special receptors on a host cell that will allow the virus to bind and then enter the cell. Acquired immune deficiency syndrome, AIDS, is the most common secondary immune deficiency disease in the world. First identified in 1981, HIV/AIDS is now a serious worldwide epidemic. Hardest hit groups are the 25 to 44-year-old men who have had sex with other men, and minority groups of African American and Hispanic origin. Women often have worse outcomes due to a delay in seeking care. Currently in the United States, almost 1 million cases of HIV/AIDS have been diagnosed, and more than 550,000 people have died from AIDS. Worldwide, AIDS has caused more than 30 million deaths, and an estimated 40 to 60 million people are currently infected with HIV. Most AIDS cases in North America occur among men who have had sex with other men, about 46%, or persons of either gender who have used injectable drugs. The demographic for the infection indicate that the perception that HIV/AIDS is only a problem for homosexual white men is absolutely false. More than 72% of new HIV infections reported in the United States occur in racial and ethnic minority groups, particularly among African Americans and Hispanics, as mentioned earlier. Age-related decline in immune function increases the likelihood that the older adult will develop the infection after an HIV exposure. In the older woman, thinning of the vaginal tissue as a result of decreased estrogen may increase susceptibility to all sexually transmitted diseases, including HIV infection. Women are the fastest growing group with HIV infection and AIDS. In North America, about 16% of people with HIV infection are women. In less affluent countries, 50% of cases occur in women. Risk factors are sexual exposure, 75%, and IV drug use, 25%. Women with HIV infection have a worse outcome with a shorter mean survival time than that of men. This outcome may be the result of late diagnosis and social or economic factors that reduce access to medical care. AIDS is a disease with a high mortality rate. The fatality rate is at least 60% for adults, and to date there is no cure, just like other viral diseases which have no cure. Thus, a major focus for healthcare in North America and worldwide is prevention of HIV infection. For those infected with HIV, drug therapy slows the progress, and to be effective, it must be taken as prescribed for the rest of the patient's life. The top 10 states with numbers of those with AIDS cases include New York, California, and Florida. In North America, men having sex with men is by far the most common cause of AIDS, and HIV/AIDS is most prevalent in the middle of Africa. Countries with the highest rates in the world exist in Central to Southern Africa, but exclude South Africa. Swaziland has the highest rate in the world at 38%, with a life expectancy of 30 years on the average. Botswana and Zimbabwe follow closely behind. Most HIV infections found in southern Africa are HIV-1, the world's most common HIV infection, which predominates everywhere except in West Africa, home to HIV-2. The first cases of HIV in the region were reported in Zimbabwe in 1985. In many parts of Africa, as elsewhere in the world, the AIDS epidemic is aggravated by social and economic inequalities between men and women. Women and girls commonly face discrimination in terms of access to education, employment, credit, health care, land, and inheritance. These factors can put women in a position where they are particularly vulnerable to HIV infections. In sub-Saharan Africa, around 59% of those living with HIV are female. The poor status of women in Swaziland is thought to be one of the key reasons why Swaziland has the highest HIV/AIDS prevalence rate in the world. HIV infection is preventable because it can only be transmitted through bodily fluid. HIV has been found in these fluids: blood, semen, vaginal secretions, breast milk, amniotic fluid, urine, feces, saliva, tears, cerebrospinal fluid, lymph nodes, brain tissue, cervical cells, and corneal transplant tissue. Only fluids of blood, semen, vaginal, amniotic, and breast milk contain enough of the virus for transmission. Virus does not survive well in other fluids. The greatest concentration of the virus is found in blood, followed by seminal fluid. Transmission occurs through the following means: sexual, genital, anal, and oral sexual contact with exposure of mucous membranes to infected semen or vaginal secretions. Parenteral, sharing of needles or equipment contaminated with infected blood or receiving contaminated blood products. Perinatal, from the placenta, from contact with maternal blood and body fluids during birth, or from breast milk from an infected mother to child. Contracting HIV through receiving a transfusion is highly unlikely. Blood is screened for HIV antibodies. However, there is a tiny window of opportunity when the donor has contracted HIV, but antibodies aren't yet visible. It's nearly impossible to contract HIV through the donation of blood. Blood bank collection equipment would have to be highly contaminated. The risk for AIDS transmission through blood and blood products has been reduced to a national average of 0.02%. All donated blood in North America is screened for the HIV antibody and blood that is positive for HIV antibodies is discarded. Because of the time lag in antibody production, seroconversion, after exposure to HIV, infected blood can test negative for HIV antibodies. You need to inform patients that there is a small but real possibility of HIV transmission through blood and blood products. Methods for reducing transfusion-related infections now rely less on standard transfusion therapy through more stringent criteria for transfusion, the use of growth factors to promote more rapid blood production in the patient, and an increase in autologous transfusions in which the patient donates his or her own blood to be transfused back at a later time. The CDC describes the ABC safer sex methods as A, abstinence, B, faithful, and C, condom. Abstinence and mutually monogamous sex with a non-infected partner are the only absolutely safe methods of preventing HIV infection from sexual contact. Many forms of sexual expression can spread HIV infection if one partner is infected. The risk for becoming infected from a partner who is HIV positive is always present, although some sexual practices are more risky than others. The virus concentrates most heavily in blood and seminal fluid, although it is also present in vaginal secretions. HIV is most easily transmitted when infected body fluids come in contact with mucous membranes or non-intact skin. The vagina has much more mucous membrane than does the penis. Like all other sexually transmitted diseases, STDs, HIV is more easily transmitted from an infected male to an uninfected female rather than vice versa. Teach women the importance of always either using a vaginal or dental dam or having their male partners use a condom. Sexual acts or practices that permit infected seminal fluid to come into contact with mucous membranes or non-intact skin are the most risky for sexual transmission of HIV. The practice with the highest risk is anal intercourse. In anal intercourse, the risk increases when the penis and seminal fluid of an infected person come into contact with the mucous membranes of the uninfected partner's rectum. Anal intercourse in which the semen depositor is infected is a very risky sexual practice regardless of whether the semen receiver is male or female. Anal intercourse not only allows seminal fluid to make contact with the mucous membranes of the rectum, but also tears the mucous membranes, making infection that much more likely. Teach patients who engage in anal intercourse that the safer sex practice is for semen depositor to wear a condom. Viral load, the amount of virus present in the blood and other body fluids, affects transmission. The higher the blood level of HIV, viremia, the greater the risk for sexual and perinatal transmission. Current highly active antiretroviral therapy, HAART, has caused the viral load of some infected patients to drop below detectable levels. Although there is less virus in seminal or vaginal fluids of people receiving HAART therapy, the risk for disease transmission still exists. Preventive practices to reduce transmission among IV drug users include the use of proper cleaning of the works, which are needles, syringes, and other drug paraphernalia. Instruct patients to use a clean needle and syringe by first filling and then flushing them with clear water. Next, the syringe should be filled with ordinary house bleach. The bleach-filled syringe should be shaken for 30 to 60 seconds. Advise drug users to carry a small container with this solution whenever sharing needles. Some communities have a needle exchange program in which the needles and syringes are used only once and then exchanged for clean ones. The risk for perinatal transmission to infants and pregnant patients with HIV infections is about 25% in women who are not using drug therapy for the disease, compared with about 8% for women who are using drug therapy for HIV. Therefore, encourage HIV-positive women who are pregnant to continue the therapy, or, if they are not on antiviral therapy, to start the therapy as soon as possible. HIV transmission can occur across the placenta during pregnancy, with infant exposure to blood and vaginal secretions during birth, or with exposure after birth through breast milk. Inform women of childbearing age with an HIV infection about the risks for perinatal transmission. Needle stick or sharps injuries are the main means of occupation-related HIV infection for healthcare workers. In addition, healthcare workers can be infected through exposure of non-intact skin and mucous membranes to blood and body fluids. Because of the time lag between the time of infection with HIV and the production of serum antibodies, seroconversion, infected people can test negative for HIV and still transmit the virus. The best prevention for healthcare providers is the consistent use of standard precautions for all patients. Currently, there are about 5,000 nurses with AIDS from an occupational exposure. Post-exposure prophylaxis, PEP. In the case of HIV infection, post-exposure prophylaxis is a course of antiretroviral drugs which is thought to reduce the risk of seroconversion after events with a high risk of exposure to HIV, such as unprotected anal or vaginal sex, needle stick injuries, or sharing needles. To be effective, it must be started as soon as possible after exposure and ideally within an hour. PEP should be given for 4 weeks. When a person is first infected with HIV, the first manifestations are fever, night sweats, chills, headache, and muscle aches. All of these problems can be caused by exposure to almost any virus, such as influenza, not just to HIV. Many people with this acute HIV infection also have a rash and a sore throat, which is often confused with mononucleosis and viral meningitis. With time, these symptoms cease and the person feels well again. This is called the latent phase. Actually, a war is going on in the body between HIV and the immune system. As the CD4 T-cell level drops, the patient is at risk for bacterial, fungal, and viral infections as well as opportunistic cancers. Opportunistic infections are those caused by the organisms that are present as part of the normal environment and are kept in check by normal immune function. They occur because of the profound immune suppression of the person with AIDS. These infections may result from a newly acquired infection or reactivations of an old infection. The time from the beginning of HIV infection to the development of AIDS ranges from months to years. The range depends on how HIV was acquired, personal factors, and interventions. For people who have been transfused with HIV-contaminated blood, for example, AIDS develops quickly. For those who become HIV positive as a result of a single sexual encounter, the period is much longer before progression to AIDS. Other personal factors that may influence progression to AIDS include frequency of re-exposure to HIV, presence of other sexually transmitted diseases, STDs, nutritional status, and stress. To be given the diagnosis of AIDS, as opposed to just having an HIV infection, the patient must be HIV positive and have one or both of the following conditions: an opportunistic infection or a T4 count below 200. Opportunistic infections include any infection that is rarely seen in a healthy person: fever, diarrhea, or anorexia. Everyone who has AIDS has an HIV infection. However, not everyone who has an HIV infection has AIDS. The distinction rests with the number of CD4 T cells the patient has and whether any opportunistic infections have occurred. A healthy adult usually has 800 to 1,000 of these cells per cubic millimeter of blood. The number of CD4 T cells is reduced in a person with HIV disease. Once AIDS is diagnosed, even if the cell count goes higher than 200 cells per cubic millimeter, or if the infection is successfully treated, the AIDS diagnosis remains, and the patient never reverts to being just HIV positive. The tests to determine if you are infected with HIV include the following: ELISA, a Western blot, viral load, and CD4 or T4 counts. ELISA is an inexpensive and accurate test. The patient's serum is mixed with HIV grown in a culture. If the patient has antibodies to HIV, they bond to the HIV antigens and can be detected, a positive test. However, this test can be negative even when the person has an HIV infection if the test is performed before antibodies are made in sufficient numbers. The period between when a person is first infected with the virus and when viral replication is occurring but the immune system has not yet started making antibodies is called the window period. This means that if the patient has an episode of unprotected sex with an HIV-positive person one night and comes in for testing a week later, the ELISA will be negative even though the patient may have an active HIV infection. Thus, testing during the window does not provide useful information. False positive test results, incorrectly indicating HIV infection, occur in about 0.1%, that is 1 in 1,000, of those tested with ELISA. False positive results sometimes occur in pregnant women and women who have had children, injection drug users, people who have had malaria, and patients with lymphomas and other conditions. Therefore, anyone who has a positive ELISA needs to have additional testing to confirm or rule out infection. The Western blot is used to confirm the diagnosis when the results of an ELISA are positive. This test is more sophisticated and expensive than the ELISA. The Western blot detects serum antibodies to 4 specific major HIV antigens. A positive Western blot result is based on the presence of antibodies to at least 2 of the major HIV antigens. The result is considered inconclusive if 2 of the major antibodies are not detected but other antibodies to HIV are. The person should then be retested. If a person has a positive test result for HIV antibodies, it does not mean that he or she has AIDS, only that she has been infected with the virus. Both ELISA and Western blot are blood-based tests. This requires special equipment and trained personnel to test for the HIV infection. Some HIV testing is simpler, using techniques that are not blood-based, so that the testing can be done anywhere, even at home. One test involves oral testing for HIV antibody. This test uses a device that is placed against the gum and cheek for 2 minutes. Fluid, not saliva, is drawn into an absorbable pad, which, in an HIV-positive person, contains HIV-specific antibodies. The pad is placed in a solution, and a positive result shows a change similar to a positive result in a urine pregnancy test. Total testing time is about 20 minutes. This test has the same accuracy as blood testing and can provide results quickly. If results are positive for HIV, a blood test is needed to confirm the results. Viral load testing, also called viral burden testing, measures the presence of HIV viral genetic material, RNA, or other viral proteins in the patient's blood rather than the patient's body response to the virus. These tests are quantitative and indicate the level of viral burden or viral load. Such tests are useful in monitoring disease progression and treatment effectiveness. CD4 count. CD4 T cell and CD8 T cell counts and percentages are an important pair of an immune profile. People with HIV disease usually have a lower than normal number of CD4 T cells. Some patients with AIDS have fewer than 100 cells per cubic millimeter. The normal count is 500 to 1600 cells per cubic millimeter, whereas the number of CD8 T cells remains normal. The normal ratio of CD4 to CD8 cells is 2 to 1. In HIV disease and AIDS, because of the low number of CD4 T cells, this ratio is low. Low CD4 T cell counts and a low ratio are associated with an increased manifestation of the disease. Testing should be done for any of these groups: people with sexually transmitted disease, IV drug users, people who consider themselves at risk, women of childbearing age with identifiable risks including IV drug use, engaged in prostitution, had sexual partners who were infected or at risk, had contact with men from countries with high HIV prevalence, received a transfusion between 1978 and 1985, people planning to get married, people in correctional institutions such as jails and prisons, prostitutes and their customers. Patients with HIV/AIDS are on a continuum. It's a chronic disease, with some days being worse than others. Manifestations might include non-specific problems such as shortness of breath, cough, fever, night sweats, nausea and vomiting, weight loss, swollen lymph nodes, diarrhea, changes in mental status. An opportunistic infection is an infection caused by pathogens that do not usually cause disease in healthy immune systems. A compromised immune system, however, presents an opportunity for the pathogen to infect. Opportunistic infections can be from bacteria, viral, fungal, or protozoal sources. Pneumocystis carinii pneumonia is one of the most common opportunistic infections. It is protozoal in cause, and it is characterized by dyspnea on exertion, cough, and fever. Generally, it is treated with Septra. Mycobacterium avium complex is bacterial. It infects the respiratory and GI tracts. Patients with MAC have fever, sweating, weight loss, and dyspnea. MAC is the most common bacterial opportunistic infection. MAC bacteria are common in the environment and cause infection when inhaled or swallowed. Symptoms of MAC diseases are reminiscent of tuberculosis. They include fever, fatigue, and weight loss. Many patients will have anemia and neutropenia if bone marrow is involved. Pulmonary involvement is similar to TB, while diarrhea and abdominal pain are associated with the GI involvement. MAC should always be considered in a person with an HIV infection presenting with diarrhea. I think of it as TB that can also become systemic and get into the lymph and bone marrow. Mycobacteria tuberculosis is a respiratory infection caused by bacteria, TB, and it occurs about 10% of HIV patients. The patient will have dyspnea, fever, and night sweats. They may not have a positive TB test due to their suppressed immune system. The typical symptoms of tuberculosis are a chronic cough with blood-tinged sputum, fever, night sweats, and weight loss. Infection of other organs causes a wide range of symptoms. The diagnosis relies on radiology, commonly the chest x-rays, a tuberculin skin test, blood tests, as well as microscopic examinations and microbiological culture of body fluids. Tuberculosis treatment is difficult and requires long courses of multiple antibiotics. The TB bacteria cause fibrotic areas in the alveoli affecting respiration. Gastrointestinal problems include the fungus Candida and the protozoa Cryptosporosis. Fungal infections occur by overgrowth of normal body flora. Candida albicans is part of the natural flora of the intestinal tract. In the person with AIDS, candidiasis, overgrowth of the Candida fungus, occurs because the weak immune system can no longer control fungal growth. Candida stomatitis or esophagitis is a frequent finding in AIDS. Patients may report food tastes funny, mouth pain, difficulty in swallowing, and retrosternal pain, pain from behind the ribs. On examination of the mouth and back of the throat, you may see cottage cheese-like yellowish-white plaques and inflammation. Esophagitis is diagnosed by endoscopic biopsy and culture. Women with HIV disease or AIDS may have persistent vaginal candidiasis with severe pruritus, itching, perineal irritation, and a thick white vaginal discharge. Oral candida, thrush, causes pain in the mouth and esophagus, making it difficult for patients to eat. Candida also affects the vagina, leading to pain and itching. Women who go to medical providers with vaginal infections frequently should be assessed for HIV. Cryptosporosis causes severe diarrhea, with the patient having 10 to 20 watery stools and liters of water loss per day. Patients will be treated with a micellar-troche for Candida and Flagyl for cryptosporidosis. Patients with severe diarrhea need frequent small amounts of bland food with no milk products and lots of water to replace lost fluid. Wasting syndrome is a result of diarrhea, inability to eat due to anorexia, and pain with swallowing. Patients may develop a catabolic state where muscle must be used for energy due to a rapid metabolic rate. Kaposi sarcoma is a malignancy that only occurs for patients with AIDS. Although the skin lesions of KS may be disfiguring, they are usually not life-threatening or disabling. In most cases, the lesions cause no symptoms. In some, the lesions may be painful, especially if they cause swelling of nearby unaffected skin. Kaposi's sarcoma does become life-threatening if it's in the lungs, liver, or gastrointestinal tract. This can cause major symptoms. Kaposi's sarcoma in the gastrointestinal tract, for example, can produce bleeding, while tumors in the lungs may cause difficulty in breathing. Kaposi's sarcoma appears as a purple-brown raised lesion. Neurological infections include encephalopathy caused by Toxoplasmosis gondii, a protozoa. The toxoplasmosis is contracted through cat feces or uncooked meat. This protozoal infection of brain tissue leads to confusion and poor judgment and can cause the patient to injure himself. Number one nursing diagnosis or problem is a risk for injury. Immunocompromised patients, such as those with HIV/AIDS, those taking certain types of chemotherapy, or those who have recently received an organ transplant, may develop severe toxoplasmosis. This can cause damage to the brain or eyes. Meningitis, an inflammation of the meninges, can be caused by cryptococcosis, a fungal infection. A way to check for meningitis is to ask the patient to bend the head down and look at their feet. This checks for nuchal rigidity, which is a classic sign for meningitis. Cryptococcosis is a debilitating meningitis, and it is sometimes a widely spread infection in the AIDS community. It is caused by Cryptococcus neoformans. You want to ask about fever, headache, blurred vision, nausea and vomiting, nuchal rigidity, the stiff neck, mild confusion, and other mental status changes. Some patients have seizures and other focal neurological problems, or they may have mild symptoms of malaise and fever with or without headaches. There's a major risk for injury with HIV. The mental decline associated with HIV, the virus which causes AIDS, is one of the most feared complications of the infection. Cognitive or thinking impairment in people with HIV has many possible causes. Tumors or infections, side effects of medications, depression, alcohol abuse, and stroke. HIV infection by itself can also cause cognitive decline, a syndrome referred to by most authorities as AIDS dementia. Dementia is a general term for a decline in a person's intellectual function. Demented patients are awake and alert. They just have varying degrees of cognitive impairment. Approximately 70% of AIDS patients are affected with dementia due to the viral attack on brain tissue. Herpes comes from a viral infection, herpes simplex virus, HSV, and can occur in perirectal, oral, and genital areas. Patients may have fever, pain, and bleeding at the lesions, and eating may be difficult. Women are more likely to have the herpes virus, human papillomavirus, and vaginal candida. HPV can lead to cervical cancer, so women with chronic infections such as these should be checked for HIV. There are several drugs being used to treat HIV. The goal of the HIV drugs is to stop the virus from replicating, so the immune system will have a chance to do its work. Patients are given a regime of highly active antiretroviral therapies, HAART, or HART, to hit the virus in 3 different ways. There are NRTIs, nucleoside reverse transcriptase inhibitors, such as zidovudine, which also goes under the names of retrovir, lamivudine, or epivir. A major side effect of zidovudine is bone marrow suppression, which will lower complete blood counts. There are NNRTIs, which are non-nucleoside reverse transcriptase inhibitors, and that includes nevirapine, Viramune, efavirenz, and Sustava. Finally, there are protease inhibitors, Indivir, Sirixavan, Nelfinavir, and Viracept. This is a list of some of the most common drugs used to treat AIDS. The first drug on the market was in 1987, zidovudine. The latest drugs on the market are in the family of fusion inhibitors, which were developed in 2003, Fusion. When treating PCP, Septra might be used, but there is a risk of liver toxicity and more immunosuppression. Another drug for treating PCP would be pentamidine, which might be given either intravenously or by aerosol. It can cause severe hypotension and hypoglycemia. It's often started with a test dose. When there are GI infections, flagyl is often used, and the hope is to decrease diarrhea. Mycelex troche might be used to treat oral candida, and fluconazole, diflucan, can be used for fungal infections such as systemic candida or cryptococcal meningitis. Rifampin might turn body fluids such as urine, sweat, tears, and saliva orange. This is a harmless side effect. Anti-tuberculosis meds might cause further immunosuppression, and you must monitor hepatic function. Fungizone might be used for cryptococcal meningitis or for severe candida that is not responding to anything else. It's a nasty and potentially dangerous drug. Often a test dose is first given to see if there's a reaction. It's very nephrotoxic, and it may cause extreme chills when first given. Ganciclovir is used to treat the cytomegalovirus. Cytomegalovirus, CMV, can infect many sites in persons with AIDS, including the eye, CMV retinitis, respiratory and GI tracts, and the central nervous system. CMV infection can also cause many nonspecific problems such as fever, malaise, weight loss, fatigue, and swollen lymph nodes. CMV retinitis impairs vision, ranging from a slight impairment to total blindness. It can also cause diarrhea, abdominal bloating, discomfort, and weight loss. Ask the patient whether he or she has had any of these manifestations. In addition, CMV can cause encephalitis, pneumonitis, adrenalitis, hepatitis, and a disseminated infection. So the ganciclovir is used for severe CMV retinitis. Acyclovir can be given by pill or IV to treat herpes or shingles. Herpes simplex virus infections in people with HIV disease or AIDS occur in the perirectal, oral, and genital areas. The manifestations are more widespread and of longer duration among patients with HIV/AIDS than among those who are immunocompetent. Numbness or tingling at the site of infection occurs up to 24 hours before blisters form. Lesions are painful, with chronic open areas after blisters rupture. Varicella zoster virus, VZV, infections, which is singles, is usually not a new infection for people with AIDS. This virus, present in the nerve ganglia of many people, causes chickenpox. When people who have had chickenpox previously are immune compromised, VZV leaves the nerve ganglia and enters the body fluids and other tissues, causing shingles. Finally, if you review the notes, I've gone into much greater detail on the drugs for HIV, and I strongly recommend you read the notes because it will talk about each of the drug classes.